Kick it all off by thinking about the overall arching topic of the second session, which was global health. And I really like the idea that you don't necessarily have to make the trade-offs between quality and cost and accessibility. But at the same time, there are some trade-offs, right? And at ISB, we're trying to develop things like personalized medicine, personalized approaches, precision approaches, and those things are inherently sort of expensive from a research side to develop. But are there things that we could be targeting and thinking about in translating these more personalized, more precision approaches to global health a priori? Are there ways to integrate, say, things we can easily measure, like cell phone data, with some of these molecular measurements and kind of marry the two to more rapidly create kind of cheap therapeutics that we can expand rapidly? And if you had any thoughts on that.
No, that's a good question. So one of the things that's interesting about the work that we've done is we actually started out with domestic use cases, and it turned out there's a lot of need in the global sector, but it turned out that just the need in terms of being able to try something quick and iterate on it really helped innovate in that space. In particular, if we were trying to go after the best model possible that has like the right, the perfect sensitivity, specificity, but it turns out that you don't need to get that far. You can start to get something in the field and get feedback early, where if you look at it as a case finding tool or screening tool where you do have other mechanisms to be able to have backup plans, it went a long way. And it allowed us to really deploy these things out into the real world much sooner than we normally would, right? You're in the clinic, doing all these studies where if we were able to deploy it sooner, we were able to get a lot more feedback where it really nudged our research in a direction that we never thought it would go. And that's one of the things that we've been looking at is, some of the phone-based approaches are never going to replace, a traditional diagnostic. It's just not going to happen, right? I mean, there's kind of things that we're going to get close to, but one of the things to think about is you don't have to be perfect. You can actually create a system around the diagnostics and screening tools so that you can start to innovate new ways to scaffold around it rather than trying to go after that perfect 99.9% accuracy. And that's a battle I quite often fight with colleagues. It's like, no, your thing's not accurate enough, it's useless. But it's like, no, I think there are other ways to get things out there, and even if it's not perfect or if it's noisy, there's still value there. I think trying to think about it from that standpoint might be an interesting approach.
Yeah, I would just quickly add that to the extent that we can have some intentionality early on in considering the question and thinking about solutions, that would be good. The history has been, if you look into the past, that as different advances have been made, generally there's been 5, 10, even a generation's period of time before people have figured out how to take the nature of that innovation and produce it and make it accessible in a way to the poor world. The good news is that generally smart folks have figured out a way to make that happen. And that's why if we can be intentional and begin to think about how to make that happen earlier, we can maybe save that generation's worth of time.
I make a plug-in for transferring concepts and practices to school systems. I think there's a really long delay between when an invention is made, a new concept is figured out, and when students get to learn about it in the classroom and how they learn about it. I think that pipeline also can be in a shorter time frame where you engage scientists in the curriculum development process, but also engage the educators and students. So it's not just technologies making it into the marketplace, but it's also the concepts and practices that enable and empower students and educators to become part of this whole problem-solving process. And oftentimes we think of students as only consumers of knowledge, and especially with the gaming and smartphone technologies, you can actually make them participate in the problem-solving process where they learn and they contribute at the same time.
Yeah, no, I actually second that. There's often when I'm, working with undergrads, grad students, there's a big disconnect in terms of, kind of where their education ends, and then when they're doing this research or thinking about these problems, and they're going through the retraining process again, right, to figure out, how do I translate this, or what are some of the problem domains I need to think about. But introducing that earlier in the curriculum makes a huge difference. I think they can really hit the ground running that way.
No other questions from the audience? If not, I'll jump in with more of my own. Okay. So I really like that. Another way to bring down cost and translate science better into society is to leverage publicly available data that already exists. And Bryan, I really like the approach of being able to pull down all these data sets across batches and bring them together and compare them. But I tried to read your preprint quickly before this panel, but I wasn't able to get to it. It looked like a supervised approach, so you know the batches a priori. Do you also have to know the cell types that you're feeding in a priori as well?
That's a good question. So in that initial kind of training study, we said what we wanted to say is, like, if we have a gold standard data set and we know that kind of a immunologist has decided that these cells that I sorted are CD45 double positive for blah, 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 and this is the transcriptional signature I see by single-cell RNA-seq, how do I take a gold standard label and like integrate that? But now the method is actually totally unsupervised. So it actually doesn't require, all it requires is the input matrices. You don't really require any additional information on top of that. So I make a huge plug for understanding, like, using other people's data to help inform your own experiments, because A, it saves in costs, and two, I think one of the things, especially in the single-cell RNA-seq world, is a lot of these papers come out and say, we found this rare population of macrophages in this disease. And actually, if you actually start to begin to aggregate all of the data sets and then say, actually, is this rare population exclusive to that disease, or is it kind of more a rare population in many, many different diseases? What we're beginning to observe is that actually this rarity is actually conserved across many different disease states. So I think use other people's data to your advantage, because I think it saves you from going down a rabbit hole that could be not misleading, but not the complete story.
Yeah, just thinking about data sets in general, there's kind of right now with some of the new advances in AI and machine learning, I mean, you're kind of data constrained with some of these black box techniques. And so there's a lot of these initiatives in terms of getting the data sets out there and making them publicly available. And one interesting thing that's happening in the computing community is that there's organizations that are just being established just to create and cleanse these data sets. Like, for example, Eric Schmidt has an organization that's just trying to capture and cleanse and de-identify all the EHR data, right? I mean, that's a pretty brutal effort that most academics aren't going to do, most companies aren't going to do, but you can have organizations that are there to actually at least seed and enable these communities where we're just going to do the gory, dirty details and just create that data set, right? And so I think we're seeing a lot more of those kind of efforts popping up, and I think that's something we should start to encourage as well, because it's going to really move all of science forward if somebody's willing to take on these kind of gory details.
So I think I mentioned in my presentation that we were able to build a full cell model for tuberculosis, Mycobacterium tuberculosis, before we did any experiment, because we could go into the public domain and assimilate all the data sets generated by, I think, about 30 different labs through 53 different studies. The labs didn't design the experiments with the intent of having the data integrated, so we had to come up with ways to deal with batch effects. But that's a good place to start, is to build a model and then use that model to help you prioritize which experiment to design and go after. And I think that's becoming more and more possible to do, also because journals and funding agencies are all aligning themselves to making data standard format, more accessible, better annotated. And there's journals that have come up as well. There's one, the only one I think is Nature Scientific Data. And I'm on the editorial board of that journal. The only purpose of the journal is to make sure data sets become available in a way that people can use it for the intent that they were, beyond the intent that they were generated for. And the thing that maybe this audience should also know is that you can publish the same data sets that were published in some other journal just for the purpose of releasing it, and that is allowed. It's just not something typically done by other journals.
That's cool.
And along those same lines, thinking about whether or not we're sampling, we're talking about heterogeneity, right? Whether or not you're sampling across all the heterogeneity we could be sampling across, especially in a global context. I think you should leverage all this existing data just to know where you want to target your next study or your next advance is going to be. But where should we also think about collecting more data to better apply our work to other groups, to other countries, to other regions?
So as a non-clinician, I often am very envious of the fact that developing clinical cohorts is actually really important to be able to capture information that you can't capture if you just get a healthy Luca pack from the hospital, because I think it's becoming immensely clear, like the contribution of ethnicity, gender, like really, especially as we do all these immune profiling studies, I think that really matters. And so I think ways to better partner when you are just a PhD scientist, partnering with people who have the capacity to build clinical cohorts so you can really try to build out the kind of the heterogeneity and sampling that you can do in terms of the populations that you access, I think is actually really important, because I think I don't want to just only be able to come up with a predictive signature in a particular single population of people. I think it's important to have a lot of diversity in the immune donors to begin with.
I'm going to put in a plug for data in a different way, and that is that the work that you all are showing, it's profound what you're able to do with the data that you have. In the clinical world, nobody would ever think to operate a clinic without having a individual medical record, optimally an electronic one. That's fundamental to good practice. Once you move out into the community, though, all bets are off. And this idea that government policies, that public health practitioners, that people in communities should be, in essence, conducting interventions on that community in the absence of having that foundational data set is the current reality, but is horrible when you think about it. And what we need to be doing in the future is to recognize that as we're trying to approach communities and improve community health, that fundamental to that is the creation of what I would call a community health record, of having a set of information that is increasingly possible with the data sets that are available, that is the real life record of the health of that community, of the various interventions that people in the community are trying, and documentation of their success or not success. We're not there. It's amazing when you think about it. We are light years ahead of where community data is when you get to the individual health record or to research. And this is a problem that's solvable, but we need to start tackling it.
I actually have a question for David. So Peter Small just co-authored a nice article, I'm sure you read last week, about Seattle being this cross-disciplinary haven for going after diseases like tuberculosis, where you have so many institutions who are innovating and also working directly with the patients. And so we have the whole spectrum of activities here. My question to you is, to what extent do you think we are fully leveraging those capabilities in a city where all the expertise seems to be there? When, for example, in PATH, you showed technologies that could make solutions accessible where they were needed. The other way around, do you know of needs that exist in the places that you work with, where the innovations that are required are being worked on by scientists, and how would you see that being communicated? So 2 questions there. Are we fully leveraging our capabilities? And 2, how could we help you better to bring the innovation that you need to the marketplace?
It's a great question, and it's kind of a glass half full for me, which I think that we are very lucky here in Seattle. First off, Seattle probably has on a per capita basis among the highest concentration of global health expertise of any place in the world. Maybe Geneva would beat us out. I don't know. So we have this huge gift of these organizations. And second, there is a ethic in Seattle of collaboration and cooperation, where people actually want to work with each other for the most part. This has been leveraged by an entity that's called the Washington Global Health Alliance, which is essentially an organization that is trying to bring the different institutions together in that upstream down way that you've been talking about, but we haven't fully leveraged it. On the other hand, when I go around the country sort of espousing the value of the Washington Global Health Alliance to other places, unnamed places on the East Coast, people look at me like we're crazy. Why would you all want to work together? Don't you feel that you're competing? So the foundation, the ecosystem is right here, but we haven't quite gone to the step that you're talking about, which is to actually make those connections happen, particularly on the upstream downside in a prospective way that maximizes our ability to be effective. So I'm open to ideas about how to do that. As a result, I don't know if you all saw it, of the article that Peter and Gabrielle put. PATH is going to be working with Peter to try to bring together a focused effort specifically around tuberculosis as a case starting point to try to make this happen. So learn by doing.
So along those exact lines, if you were, I would imagine, you just had a conversation on medical records, and then we've talked about deep molecular phenotype and all these things. I would think that if you were going to start on a TB project like this, what do? Do you go take a geographic region that has this is a big problem and start trying to collect medical records? That seems to be or at least establish medical records. That seems to be the lowest bar one would need to get over before you start even doing any kind of molecular phenotyping.
Others here are better equipped to answer this than me, but I think it's a both and, actually. When you take any disease, and even tuberculosis with all of its complexities, there probably is not a single answer to bringing it under control. It's very basic upstream medical research, basic science research. It's the development of new drugs and diagnostics, all the way down to, in a world of the future, using those medical records you're talking about, using AI or some sort of algorithm to better help the frontline clinician and the public health practitioner figure out which of the patients that they're following are the ones that they need to be spending more of their resource on because they're the most likely to fail or drop out, and who are the folks that we can actually pull back on resources because they're probably going to do just fine. So you think about these complex problems that we're facing, and we do need to get together and work, but we also need to recognize that that work has to be in multiple streams.
Yeah, I think the place where I struggle with is we have technologies, for example, to profile the pathogen at very high sensitivity. And we could bring that technology to the clinic so you can do sputum diagnostics. And the research, leading edge research tells us that knowing what the state of the pathogen is could inform us in ways that we can treat the individual in a very tailored way. Now, but that seems so far in the future to Jim's point and to your point. I think how you get from where we are with that technology to democratize it. It's not like a cell phone app where you can just detect a cough. It's going beyond that in terms of getting down to that detailed information that becomes actionable in a clinical setting. So that path seems like it's 10, 15 years out. How can we shorten that runway so we can get this transfer of capabilities much faster? And you need these kinds of partnerships because scientists themselves will keep making the technology better, but it'll never get close to the clinic unless we actually make it happen.
I think bringing the idea back to, oh, sorry, Sui, you go ahead.
Yeah, it's related to what Nitin just said, but it's a more broader question to everybody in the panel. And I actually have a problem with the composition of a panel because it actually shows a problem. And that session is about from concept to global health, right? And I see now a problem here. We have two panelists who are, I think, David and Shwetak. You are trying to deploy knowledge to the world using innovative technologies and logistics. So this is a technological and logistical problem. On the other hand, of Nitin and Bryan trying to gain new insights into a disease, which is cutting-edge science and innovation at the scientific front. And I think these are two different domains, and we keep mixing them up, but maybe it is also an intersect that could be productive, but it doesn't need to be. It could be just two different domains. So how do we deal with that? You know, science on the one hand, new knowledge versus deployment of existing knowledge using innovative technologies. Can we just separate these two or not?
I don't have an answer, but I can tell in global health, it's particularly difficult because there's no market forces driving the translation from a scientist perspective. So you can't think of having the economics of technology transfer to, for example, if you go to GSK and say we have this new drug combination that is very effective, GSK may be the only company that will listen to you. All other companies have moved out of the space because there's no way they can make money out of it. And so the translation is indeed, to me as a scientist, when technology transfer, even in the best case scenario, is difficult, here it is even harder. I don't know what your experience is there.
No, you're right. I think that a fundamental reason why those maps that we were looking at show those profound differences is a market failure. I was talking with someone, the equity or inequity is essentially a solvable problem. By virtue of the fact that there is an equity, it means that we have solutions that are working in one place. We just haven't figured out how to apply them someplace else. To your second point, one of the fundamental reasons why we haven't deployed them in other places, though, is because the existing market forces are driving this, and therefore there is not the market in those places. There's lots of work that has been done, as you know, by the Gates Foundation and others to combat that. There are a number of innovative financing strategies out there, including donors stepping up and creating artificially the market forces in advanced market commitments, for example, that will get us down that line. But it doesn't get to your point of how do you link that back to that upstream work. That's I think the problem we were talking about. A small piece of this, and I really would want everybody to say their opinions, is to the extent that we can somehow create early linkages in that scientific investigative processes so that the scientists who are doing the basic research have a sense, more clear sense of what the needs and what the applications for that research might be that would guide them. In my world, this boils down much more simply to having our experts who are in delivery working with our folks who are developing their products so that the target product profile that they're developing has actually been thought about in advance for one that would work in the conditions in the field. What we're talking about here is a much more complex adaptation of that. But in order to link the two, there's got to be intentional communication.
So as somebody who's just starting his lab, I'm going to chime in here a little bit. And I think one of the things that I, having spent a postdoc in a school of public health, you become immensely clear, getting a PhD at MIT in engineering, you were trained to what is the best technical solution. But I think, the reality of working in a place where there maybe are not market forces that let the best engineering solution always win, there is a reality that it's your best engineering solutions subject to the environment that you're in. And so one way that I think we've tried to do this in my lab is I actually have a rule that nobody's allowed to graduate until they spend a month in a TB endemic place. And the reason for that is it is kind of almost essential that you see that it's not just about developing the best technologies, it's about like contextualizing the impacts of your work. And so that's at least one way that we've tried to bridge it when there really aren't like really great mechanisms. And we've just been like very thankful of the donor who like pays for my students to take these trips. But I think that's one way that we've been trying to at least make it such that it's not exclusively TB, it's not an academic exercise. Like TB is a real global health problem. We just don't see it very much here. And so I think it's essential to like, you know, where we don't necessarily have the mechanisms that where you can like literally go to the clinic and collect a sample from a cancer patient and then go and analyze it in your lab and like see that cancer patient and see that full experience. You really, I think at some level, have to like create those experiences for the people such that they can understand like how do they contextualize and make impact there.
Great. Well, that brings us pretty much up to the time, I believe. So any last questions before we leave it off? All right. Well, I think now we'll have a poster session. So please join us. And let's thank the panel for these amazing talks.